Good morning, good afternoon, good evening, everyone, depending on where you are. It's a great privilege to have you on this webinar series. As most of you know, at the International Institute for Primary Healthcare, we keep having a regular webinar series that's focused on primary healthcare. Today we have on a webinar on accountability in primary healthcare. We have great speakers that are lined up. I will introduce our moderator who will be welcoming and introducing the speakers for our webinar today. For those of you who may be new to the International Institute for Primary Healthcare, let me say a few words. International Institute for Primary Healthcare is established by the Ethiopian Ministry of Health back in 2016. We envision to become a center of excellence in primary healthcare. We do support capacity building both at national and global level, engaged in knowledge generation and management, in advocacy. In this month, we had hosted an international conference on primary healthcare, which is attended by over 600 people from over 50 countries. So allow me to introduce you our moderator for today. Dr. Bernard is currently professor of the School of Medicine and Health Sciences at Rosario University in Bogota and representative of the National Intersectoral Commission of Human Resources for Health before the National Intersectoral Commission of Quality Assurance of Health Academy Programs in Colombia. He is a public health and family physician with more than 20 years of clinical and managerial experience, mainly in primary healthcare services in Colombia, particularly serving marginalized communities, internally displaced persons, and patients with non-communicable chronic diseases. He has also been involved in health promotion and community building programs with vulnerable Aboriginal and migrant populations in Sydney, Australia, and Bogota for several years. His expertise extends to the fields of immunization, considering his previous work as Regional Director of Clinical Sciences at Sanofi Pasteur for several years, leading clinical teams and conducting epidemiological and clinical studies for the development of new candidate vaccines to prevent and control infections such as dengue, Zika, genital herpes in Colombia, Peru, Brazil, and the United States of America, as well as advocating in favor of immunization of public health interests in the same countries. He worked at the Colombian Ministry of Health as National Director of Human Resources for Health in 2019 and 2020, where he contributed to policy design and the deployment of strategies to strengthen primary healthcare and the overall healthcare system, as well as the development of human resources for health in the country. He was part of the National Public Health Strategic Committee that prepared and implemented the response of the Colombian health sector to the COVID-19 pandemic. As the Ministry of Health focal point, he joined the Primary Care Performance Initiative in 2019, and in the last years, he has been consultant for the World Bank in primary healthcare topics in Colombia and El Salvador, and consultant for Results for Development Institute as expert technical facilitator of the PHC International Community of Practice with Joint Learning Network for Universal Health Coverage. He has also been consultant for PAHO and USA to strengthen primary healthcare and human resources for health in Colombia. Furthermore, he has held various academic positions in different universities in Colombia, accumulating 17 years of teaching experience at several schools of medicine and health sciences in undergraduate and graduate programs regarding primary healthcare and other public health topics. Several papers have been published related to his work experience. Welcome, Dr. Bernal, and over to you.
Thank you very much, Dr. Antone. It's a pleasure to be with all of you. I say hello to the speakers and to the audience. And It's been a pleasure to moderate this session that addressed a very important topic, which is accountability in primary healthcare. For sure, a strategy, a very important strategy of governance in primary healthcare, in which citizens engage individually and collectively with the different health system stakeholders and actors, healthcare providers, authorities, in order to keep them accountable on the roles and responsibilities and roles and action they have to deliver in order to keep the health system working and meeting the population health needs. We'll see how accountability is nowadays considered a very powerful tool to improve accessibility, quality of healthcare services, availability, responsibilities, and so on. So as our speakers will talk about presenting their own experiences. So without any other word, I will start presenting our first speaker, Dr. Janet Rebecca Hunter. She has worked in senior management positions in and outside of the public sector for the past 36 years. She's currently the Deputy Director General Primary Healthcare at the National Department of Health of South Africa. She came into this position from the position of Chief Executive Officer at the Health System Trust. For the past 4 years, starting in April 2018, Janet has been the accounting officer for the Northwest Department of Health. She returned to her role at the National Department of Health of South Africa on 12 July 2022. She has extensive knowledge and experience in strategic planning, policy development, planning and design for policy implementation, implementing monitoring and evaluation systems, and the implementation of information systems. Janet has a solid track record of achievement throughout understanding and successful application of strategic and operational planning processes, change management, project management, continuous quality improvement, and human dimensions management strategies. She has had exposure to the international arena in the form of short courses and international meetings, amongst others being Singapore's Civil Service College in 2000, and Harvard University's Public Health School in 2014. World Health Assembly meetings in Geneva, World Health Organization meetings on the African continent, 2 BRICS meetings in Russia, and health system conferences in China and Kazakhstan. In December 2019, she was part of a team conducting a study of how the Turkish health system has moved to universal health coverage. So Dr. Janet, welcome, and she will talk about South African experience on accountability in primary healthcare. Go ahead, Dr. Janet. I think your mic is still off. Okay.
Thank you. Thank you very much, Professor Bernal. Good afternoon to everyone. It is a huge pleasure for me to spend this time with you, to share with you a snapshot of South Africa's accountability framework as it ties to primary healthcare services. We will just do a brief background. Also, from our viewpoint, what are we accountable for in the health system and in primary healthcare? I share with you what I see as the 4 most important areas of accountability pertaining to primary healthcare, how we are facilitating accountability in South Africa, again with a focus on primary healthcare, then what we use in South Africa as our quality improvement and accountability framework for primary healthcare services, briefly talk about challenges, and then I have a summary. This is South Africa. We have 9 provinces and we have 52 districts. Health services in South Africa is set up according to the district health system. We provide primary health care through the district health system. And so we have 52 districts with appropriate structures, and I use the word structures very deliberately, because we don't have the staffing that we prescribe in all 52 districts. But we do know what we should have, and colleagues in provinces and districts are working to progressively comply with the prescribed structures. Those 52 districts are divided into 202 sub-districts, and this is to bring service management closer to where people live, and those sub-district structures are also appropriately defined. And again, some would be manned as prescribed, but others would not be. And across the country, in the sub-districts and in the 52 districts, we have 3,471 primary healthcare facilities. Those are all just fixed facilities, which are clinics and community health centers. And through the quality improvement and accountability framework that we set up, we realize that clinics need managers, and we call those managers operation managers, because every primary healthcare facility needs to have someone who's accountable for the services, not just for the services in those facilities, but for the quality of the services in those facilities. So what are we accountable for? You can also ask the question, so what do we stand for as South Africa's health system? And this slide tries to put it all on one screen, starting with community-based services, and our community-based services are community health workers services as well. From there, we move to the clinical services provided in our facilities. Yes, primary healthcare facilities, but we are quite cognizant of the fact that you from time to time do need your higher level services to be able to refer people with more complicated health conditions too. Of course, we need our diagnostic and paraclinical services. You need adequate medicine supplies. You need your emergency medical services. And those services are based on a well-functioning referral system right from the community to the highest level. And for them to work, you need those different administrative services. I'm not going to go through them since I only have 10 minutes for this presentation, but I do want you to note that right at the bottom, and it's at the bottom because it forms the foundation, you have leadership, governance, and community participation. The vertical bars on the right are those linkages services, starting with training, communication, and so on, that you need to support both your clinical services and your administrative support services to, at the end of the day, arrive at quality, as we indicate with that blue vertical bar that's got an arrowhead, because that is what we want to move to, is quality health services. And this is what we see the health system should set up to be able to, at the end of the day, arrive at quality services. So when we look at accountability in primary healthcare, so in society in general, there are different areas where accountability is important. But in primary healthcare, from my viewpoint, there are 4 areas that's of utmost importance, and that's the political sphere, it's the administrative sphere, it is the role that communities must play in terms of accountability, and then also civil society. I explain what I mean by that. When you talk about the political sphere in South Africa, we have our parliament and cabinet and the Presidential Health Council. Let me stop there. You may think we're talking primary health care here, we're talking services on the ground. So why am I starting with the parliament, the cabinet, and the Presidential Health Council? The Presidential Health Council is chaired by the president of the country, and it's here meeting with the 9 premiers of the provinces. This very accountability framework that I want to talk a bit in this presentation was approved in cabinet. It was taken and presented to Parliament, and one of the lower houses of Parliament, which is our National Council of Provinces, to this day keeps a keen eye on how we are progressing with the implementation of that framework. And so from the political, you move to the administrative. We also explain there what we mean. We come down to community, the community sphere, where we have clinic committees that play an important role to form a bridge between what happens in the clinics and the communities, and also to give the communities feedback in terms of how they experience their services. And the clinic committees actually manage our patient satisfaction surveys for us at our primary healthcare facilities, and also based on how they experience our community-based services. We have open days for the clinics where, again, there's dialogue between facility management staff and the communities that they serve. And then, of course, very important, our NGO sector, professional associations, and societies that often, through their monitoring role, they act as pressure groups for government to remain accountable for what we are supposed to do. Colleagues, these are the structures that facilitates accountability. Again, I wouldn't want to spend time on this slide, but it's there for further discussion during the question and answer session. Just to say that at all levels, yes, our Minister of Health signs a performance agreement with the President, and his performance is reviewed as well. So starting from the highest level to the lowest level, we use instruments of accountability. Of course, people have to be trained. Their role has to be communicated to them very clearly. And at the end of the day, when there's misconduct, there has to be progressive discipline as well. So I want to briefly share with you that in South Africa, we have a program which we call the Ideal Clinic Realization and Maintenance Program. And again, the word maintenance in there is very, very deliberate, because you can often turn a facility into an ideal state, but then it slips back to not comply with standards. A clinic that's ideal complies with standards to provide quality health services. It also interacts with its environment to keep an eye and to try and improve the social determinants of health. And it must do community outreach to take health promotion to where people live. So we've set up a framework, and we have a website. I give it at the end of the presentation with the resources. It's www.idealclinic.org.za. It will also take you to a link and actually address itself as the Ideal Health Facility. But what I'm trying to show here is that we have a documented framework for quality improvement and for accountability. And the framework has 10 components, 33 subcomponents, and 238 elements. This slide, I've got a red arrow here to show that in terms of every element, we've assigned a level of responsibility. Because for a clinic to comply with the prescribed standards, sometimes it needs intervention from the national level, from the provincial level, from the district level, and then also the things that they can do for themselves in the health facility. We have different tools. So as I've said earlier, we've identified the framework to the T. We also have a manual which prescribes how every single element could be turned to be ideal, as we call it. But what it means is how you get every element to comply with standards. And an element, for example, is something like you have all the equipment that you need, that you have a clinic committee, and that your clinic committee has been trained on its role to be able to represent communities in service provision. Chairperson, how much time do I have left?
You can wrap up, Janet, as soon as you can.
Okay, yeah. So we also monitor our progress regularly, and When we started with this framework in 2014, we had 0 primary healthcare clinics complying. We moved in our first year to get 9.3% to comply, and last year we ended the year with 58.9% complying. I did not want to list the challenges here, but to say to you, there are many challenges, and the challenges result in unequal implementation of the accountability framework across the 9 provinces and within the provinces as well. In summary, to foster culture of accountability, there must be clear communication and orientation with regard to agreed accountability framework based on community and other stakeholder participation. There must be roles clarification. You must have instruments for written assignment of responsibilities. And that's why we even train our community members who are clinic committees so that they understand the role that they must play to represent their communities well. There must be regular supervision, monitoring, and feedback on all levels. We must inculcate the required values, and in South Africa, we call them Batupele values. It means people first, and those are listed there. Those are my sources. I thank you, moderator, and I thank the audience for listening.
Thank you so much, Janet, for this insightful presentation. As we can see, accountability in primary healthcare is not just relying on goodwill of healthcare providers, health authorities. It is just a national agreement on how the health system and the different actors should be responsible for, and the community playing a very important role requesting the health authorities and healthcare services to keep accountable on what they do and what they are expected to do. So I encourage our participants to type your questions in the question and answer function of Zoom. Our speakers can directly respond that way, or you can also put your comments in the chat box that we have here, the chat function of Zoom, please. So I will introduce our second speaker, Dr. Mesele Damte-Argo. Dr. Mesele is a public health expert with more than 25 years of experience in the management of primary health care and health system strengthening interventions and research in Ethiopia. He has a bachelor's and master's degree in public health and completed his PhD at the University of South Africa on the development of guidelines to improve the management of outpatient malaria case management to the private health sector in Ethiopia. Dr. Argo was a senior health systems strengthening advisor for maternal and reproductive health, nutrition, child, youth, and adolescent health and development programs at JSI Research and Training Institute. Presently, Dr. Argo is a deputy chief of party for the President's Malaria Initiative-funded Surveillance for Malaria Elimination Project. He collaborates actively with the Federal Ministry of Health of Ethiopia, regional state health bureaus, and development partners, and contributed to the development of national strategic plans, guidelines, and training manuals. He is serving as an active member of the technical working groups and advisory committees established at the Disease Prevention and Health Promotion, Health System Extension Program, Health Extension Program, and Primary Healthcare Services, and Good Governance Directorate at the Ministry of Health of Ethiopia. Dr. Argo, please come in.
Yeah. Janet, can you just, I want to share my slide with Janet. Please, can you do it?
Sure, please. Yes, please. Dr. Mesele will present the Ethiopian experience on accountability in primary healthcare. Would you be able to present the slides?
Yes, I can.
Okay, thank you. Excellent.
Thank you. Good afternoon, good morning, Good afternoon, everyone. Really, it's a pleasure for me to share our Ethiopian experience on accountability in primary health care. So this is my presentation outline. I do have a few words on our background, and I'll also give you some highlights about social accountability and its components. And I will also share with you how Ethiopian institutionalize and work social accountability in the primary healthcare context. And I will also try to demonstrate how we implement one of the social accountability tool called community scorecard in large scale in Ethiopia, and some few words on our achievements to date. So this is, as you know, Ethiopia is one of the populous country in Africa, the second populous country in Africa, with more than 110 million people. And we do have 13 regional states and 2 city administrations. And our health system is it will have 3 layers, and the primary layer is the biggest one, and there is a secondary and tertiary level tier. And in the primary level tiers, we do have health center, more than 4,000 health centers, and there are also more than 17,000 community health clinics or health posts, and there are about 305 hospitals, and there are few general hospitals and specialized hospitals in this country. Similarly, we do have also private facilities, like more than 7,000 private clinics, primary clinics, 4,000 medium clinics, and some 836 specialty clinics in Ethiopia. So this is the area how we organize our service to provide basic service for our community. And when we just see social accountability, we can characterize or explain social accountability in terms of this process. So an ordinary citizen who are service beneficiary or users in public or private points, and they want to be heard, and they want to include their voice in the service. And they also want to contribute in their preference and demand related issues with the service. And finally, after benefiting from the public services, they also have the right to hold accountable both the service provider, policymakers, and service delivery points. So our context is Ethiopia, especially our primary health care service is mainly institutionalized or customized in 2003 with the development of our unique flagship program called the Health Extension Program. And it was launched in 2003. And currently we do have more than 17,000 health posts and close to 40,000 health extension workers. And in 2005, we developed a model family training materials and criteria. And at this point, Ethiopia also have support from World Bank and other donors to exercise social accountability in Ethiopia. And this is the moment which health, education, agriculture, and road and other development sectors are engaged and exercise social accountability in the earlier time. And then in 2017, our health extension program developed a very close agents at household and neighbors level, or what we call women development armies. And at this moment, we had also a chance to develop our social accountability program. It includes a number of new tools and approach to be implemented in more than 500 districts in Ethiopia. And in 2017, after implementing more than 13 years of our health extension program, we want to optimize and revise some of procedures and approach. And this is another opportunity for us to develop health-related social accountability approach and tools. And we adopt the community scorecard as a tool for the Ethiopian health system. And starting from 2019, we also developed a health and social accountability strategic document, which will take us until 2024. So we implement a number of social accountability approaches and initiatives. The first one is the committee scorecard, and the other one is we do have also a good governance barometer, and this addresses a number of criteria, both clinical and administrative, and committee and healthcare providers' interest and opinions. And we do have also a managerial accountability in primary healthcare level, especially the lower level of the health system make accountable the next higher level. And this is also exercised in several parts of our country. And there are also a citizen report card, which people express their interest, their opinion, and their experience in service. And during COVID, we also developed a live phone-in accountability radio show. It helps us a lot of our service beneficiaries to demand drugs, supplies, and services, especially they got opportunity to talk with policymakers, healthcare providers, and managers. And there are also multi-sectoral accountability platforms, since health do have several determinants, including we should work with education, agriculture, water and resource, electrification. So there we do have also a multi-sectoral social accountability platform, and we do have also some exercise related to respectful maternity care. It helps us to capacitate our healthcare providers and be responsive to pregnant mother who are just visiting the health facility for delivery. And the very important thing is we have also a health post open house events. It's like a 3 days health bazaar. People can visit a health post and learn the services available and then their rights, and they demand additional services and quality services. And there is also a chance to discuss to have a discussion between committee health workers and the committee members. So we do have a committee and health facility forums, and every 3 months, health posts should organize a larger platform to listen the committee about the quality of services and the behavior of healthcare providers, accessibility, and interest of committee members. In addition to this, the Ministry of Health developed a number of advanced minimum standards as health sector reform, especially to make accountable the healthcare providers. We developed primary healthcare clinical guideline, and we have also health center management and clinical guideline. We call it health center reform clinical guideline. And for hospitals, we have the hospital service transformation guideline. This helps our healthcare providers to adhere and to work towards a high quality service. And with a good health literacy platform, the committee also can demand a high quality service based on these standards. And some of our facilities are striving towards a higher level of accountability. They want to be accredited in specific services and quality. So this is evidenced in few parts of our country and health service. As you can see in the picture here, the social accountability should have a transparency component, and we need to engage and participate communities, and there should be a feedback and a monitoring platform. So there are citizens, local authorities, and there should be also intermediaries. So we use all these platforms. We empower citizens, our healthcare providers, and the local government, and in between we use local medias, civic society organizations to strengthen the social accountability initiatives. So let me give you a little more detailed information about our committee scorecard. So our committee scorecard is led by committee members, and there are about 7 client councils who leads and manage the initiative of the committees. So this organization make the primary healthcare facilities accountable for high quality services, and they also help us a link between the committee and health facilities. So they promote health literacy at committee level and make the healthcare providers and health managers accountable to the committee and make responsive for them. So we implement in 6 steps. The first one is we developed indicators. We do have 6 indicators, which is developed based on Delphi technique. A number of experts, committee members are participated in identifying the most critical areas which can be addressed through large-scale implementation of social accountability initiative. And the second one, we establish a social accountability client council. There are 7 members who are representative of women, men, youth, religious leaders, civil servants. So these are independent representative of the committees who organize and conduct focus group discussion with 30 household members and every 3 months, and they listen, and then they also organize their feedbacks, and they also verify what they are saying through visiting the health facility and provide feedback for the healthcare providers. In addition, this organization is also responsible to organize a committee facility interface meeting. And finally, both the healthcare providers and the client council will sit together and develop actionable item, and they follow its implementation. As you can see clearly here in the picture, this is how we are conducting focus group discussions, and committee members, without involvement of healthcare providers, they facilitate their discussions and give feedback on 6 elements. So this is our conceptual framework in its implementation. As you can see in the middle, we do have 6 criteria. The first one is with the behavior of the healthcare providers. We want to make them compassionate, respectful, and caring healthcare providers. So this is one of the area where the community gives feedbacks and rate with the 5-point Likert scale measurements. And the second one is about services, equipment, and supplies. So committee members will rate the health centers or their nearest health facilities based on availability of services, what they are demanding, and the medical equipment and rooms and some important supplies. Similarly, they also provide their voice on waiting time. So we want to give them service within 30 minutes. So having clear directions, they provide us a good picture whether we are providing them in prompt time or we are not serving them. And the other is infrastructure. So the committee members also provide feedback on bathrooms, the facilities, the working areas, and sitting areas, and some important elements of the infrastructures. And the other important thing is with ambulance service in Ethiopia, to decrease the burden of maternal and neonatal deaths in several parts of the country. We do have a number of ambulances, so this is managed by committee members, and the committee wants to evaluate and provide feedback on these things and include as an important criteria. And the last criteria is about the cleanliness and safety of the health facility. So committee members are encouraged to provide feedback in these elements. So having these 6 criteria with 5-point Likert scales, they are going to rate out of 30. And this gives them a chance to have a discussion and negotiation with healthcare providers to improve their conditions. And finally, both of them work together to achieve a well-functioning primary healthcare units. And at the end of the day, we aspire to have a high-quality health services. And let me show you some of our results. So as you can clearly see in this slide, we do have more than 1,000 districts in Ethiopia, and 600 of them are implementing social accountability starting from 2017. So almost it do have some variation across regions. So 3 of our regions achieve more than 70% of their districts, and another 2 achieve between 60 to 70% of their districts are using this feedback mechanism, and only the 3 regions are just implementing social accountability tool in less than 30% of their districts. Especially in Somali, it's only 1 out of 99 districts are implementing social accountability tool that we are trying to improve after studying some of its limitations, like some of our committee members, like Somali, to have a pastoral committee. We want to customize our committee scorecard tools to be implemented in that platform. So this is some of the reference which I want to share you. Thank you so much. Over to you, Professor Lewis.
Thank you so much, Dr. Mesele, for this presentation, sharing the experience of Ethiopia, in which you present the importance of having a framework that is built among the different stakeholders and the community as well, with indicators that are important and relevant for the community, so that the monitoring and evaluation processes are undertaken. So it's definitely accountability in primary healthcare, a very strong strategy to provide participation to the community, to ensure transparency, as you said, and also to permit the dialogue among the health systems actors and the community. So we will go in depth for sure during our Q&A section. So I will continue with our last speaker. I will introduce her. She is Dr. Eleanor Hutchinson. She's an associate professor in anthropology and public health at the London School of Hygiene and Tropical Medicine. Her research focuses on the informal nature of care provision in health systems and complex intervention studies. She has two main arenas in which she works. The first is in drug shops in Uganda, where she has traced how ways of distributing medicines in these highly informal spaces are shaped by socioeconomic and political networks, policy changes, public health interventions, and social relations. The second is in the formal health systems, where she has examined how corruption shapes the delivery of primary care and is shaped by social networks and political systems within and beyond the health systems. Her research has been funded by MRC, FCDO, CDC, and Wellcome. Eleanor is currently the head of the anthropology group in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. She is also a member of the Royal Anthropological Institute and sits on the Policy and Practice Committee. Dr. Eleanor will talk about global experiences on accountability in primary healthcare. So welcome, Dr. Eleanor. The floor is yours.
Thank you very much. So today what I'm going to say, so greetings to everyone. Thank you very much for involving me in this panel. It's extremely good to be here. Two very interesting presentations before mine. And I suppose what I'm going to do today, so in terms of sort of thinking about the global experience, to think in particular about whether new ways of approaching anti-corruption could be useful when we're thinking about accountability and when we're thinking about social accountability as well. What I hope is that by the time I finish my presentation, that at least some of you, we've got a lot of participants in the audience, that at least some of you will think that actually when you're talking about accountability, when you're thinking about social accountability, that maybe borrowing some ideas, borrowing some experiences from the world of anti-corruption might really be a good and a sort of useful place to start. In terms of the previous presentations we've had, maybe this is a point at which we can think about troubleshooting when those policies have been introduced. If there are frictions or difficulties in their introduction, maybe you can turn to anti-corruption and say, okay, there are some new strategies that we can use in that to help aid better accountability in the health system. I just need to move my slide, which is not moving. There we go. Okay, so why should we connect anti-corruption and accountability, or anti-corruption social accountability, if you like? Well, obviously, at its highest level of abstraction, we're talking about governance. We're talking about governance in the health system, if you like, in relation to the building blocks of health systems. They speak to governance, but it also, when we think about it, it also relates directly to forms of accountability that we heard in the first presentation that we had. And in my work in Uganda, in Tanzania, in Malawi, and in Nigeria, and I know some of my colleagues that I work with in Nigeria are on the call, are listening in today, issues of governance and how we better govern health systems so that we can get better equitable access for people sit at the heart of what it is that we do. So there's a direct connection there already. So accountability and anti-corruption are connected then by a desire to make very substantial improvements in the delivery of public health, primary health care, as we're talking about here. But they're also connected because there's a key question for social accountability and for accountability more generally, that people working in anti-corruption in other sectors and also in the health sector have really started to hone in on. And I think in some ways they're a bit ahead of the game and we can learn a lot from what it is that they're doing. And this really is the question that it is at the bottom of this slide. Yeah, we know about different types of accountability. We've got good models of accountability and social accountability. We know that there are well executed interventions that are put in place. But what do you do when well-designed, well-executed social accountability interventions have a limited impact? When they don't create the types of results that you're expecting? What do you do and where do you turn? And the reason I ask this question is because in relation to social accountability in particular, we've had very mixed results. There's a quotation from 7 years ago from Lodenstein and colleagues about the fact that we really need to work out what these pathways to change are. How do we make sense of them? How do we unpack these black boxes? And to really understand that actually it's a combination of a variety of things. You can have really good policy, but if your broader governance and your health system context isn't amenable, then features of your social accountability initiative may fall flat. They may not work. And the motivation and the perception of providers are also absolutely critical. There are also, as were picked up on, in a later paper, 2 years later, I think, as these sort of concerns were raised more, that health systems barriers, corruption in itself, fear of reprisal, limited funding, are also major challenges to effective social accountability interventions. And while we know this in the literature, we need to start asking ourselves what it is that we can do to manage these. And this question then is something that we've also been thinking about in in corruption and anti-corruption programs. So should we start with a couple of definitions, which I think are useful? You may well know the very short, snappy Transparency International definition of corruption, but when you're talking about health systems, when we're talking about corruption and anti-corruption, we think you must have a much more complex understanding. Geertonde laid out a much better, I think, definition of corruption in 2017. And along with colleagues at the London School of Hygiene and Tropical Medicine, we decided that we needed to expand this definition. So what is corruption? So it's the abuse or the complicity and abuse of public or private position, power or authority to benefit yourself, or to benefit a group that you're part of, or to benefit an organization that you're part of. And absolutely critical to what corruption is it diverts institutions from their core aim. So this is why it undermines the health system. This is why it's a problem to accountability. And the benefits can be financial. I think we very often think about informal payments, but they might be non-material as well. Or they might be a benefit that you're expecting to accrue many years later. And there's been a long tradition in terms of looking at corruption in health systems, where we've looked at absenteeism, informal payments, inappropriate referral of patients. I think the referral of patients, when we were thinking about the first presentation that was done, that was absolutely critical. Inappropriate posting of staff is a very critical corruption problem, and pilfering of medicines. So we have a sort of a tradition of research on these what we might call intractable, really difficult problems, that when you're asking a social accountability program or project to try and manage change in a country, that these are very difficult, sticky, what you might call wicked problems, that it can be hard for them to take on and hard for them to make changes around, but which are absolutely critical if we want to improve our health systems. So anti-corruption activists have have thought a lot about accountability and transparency. And I think this is where there's a really nice connection where health systems researchers working on accountability can really borrow from a good deal of work that has been done elsewhere, which is always very useful. So Mushtaq Khan and Pallavi Roy talk about adverse settings. So these challenging contexts where formal rules are often dominated by informal rules, and informal sets of relations are much more important than the formal ones that might be laid out in policy. When you're working in contexts where that is the case, and when in those contexts there are very difficult, apparently intractable in some cases, problems, then traditional accountability and transparency approaches, they argue, are unlikely to be successful. And they've drawn on a huge body of literature to show this. In these adverse settings, power is also often very unequally distributed. And so if you're asking people who have relatively less power to call very powerful people to account, that's actually an extremely difficult thing to do and is unlikely to succeed. In these settings, economic, social, and political structures that drive rule breaking and enable corruption can often be extremely powerful. And we'll think about what it is that those do, the changes that those make to people in a moment. But also health systems limitations that drive rule breaking, enable corruption. So these are limitations that mean that health workers can't abide by the formal rules and provide a service in some settings. It's not possible to do so. There's a lack of medicines, there's a lack of consumables, a lack of staff, a lack of safe housing in some cases, few opportunities for training and promotion, a lack of oversight, and a lack of supervision. So they do two things, these powerful structures. They mean that people can't possibly deliver a service and work within the rules in some settings, but they also mean they make space for corruption as well. And when you work in these contexts, as I write, it's twice on 2 slides, this setting, you have to go beyond traditional accountability and transparency approaches. You can render a problem transparent. A classic example of that is showing how very often doctors are absent from their positions in Bangladesh, for example. And if you wanted to, you could go online and you could see in real time how many doctors aren't at work today in Bangladesh. But the problem is that that's been rendered transparent, but there isn't the power in the system to take that up and run with it and then enforce the rules, because there are all sorts of other issues going on that means that that can't be done. So what Khan and Roy argue, and what we've taken up into health systems research, is that anti-corruption strategies in these settings have to be targeted, and they have to be drawn from a very deep understanding of the political, of the economic, and of the social context in which they're occurring. What is it that's driving health workers to do this? You ask in one way. What is it that's enabling them to do it, on the other hand? And who are the actors who are involved? Is everyone involved? Are some people not involved? Are some people abiding by the rules or not? And the second thing that I think is very important, and perhaps really important in terms of social accountability, which is in these adverse contexts, in these challenging contexts and settings, when you have these intractable problems, when you are looking for a solution to make changes, they're only going to work if you have a powerful group or individual who is interested in dealing with the problem and is able to support the sort of change that you also want to see. So if you don't attend to power and you don't manage these processes, then it's very difficult to make these changes. Finally then, and I realize I've just gone over time, a quick example. Colleagues in Tanzania at Ifakara did some research with us when they were looking at informal payments that were being made in urban clinics and hospitals. And certainly informal payments in Tanzania have fallen, but there were still high levels of informal payments in particular areas or specialisms, and these were organized by different types of actors. So I just want to present this to you to show you about the real depth that you need to understand to try and make changes around these apparently intractable problems. So for example, we found that there were 4 different types of either individuals demanding payments from an individual or from their family, or there were cadres of different cadres of health workers were getting together to create networks to organize informal payments in outpatient departments to queue jump. And I'm not going to go through the others because I think you can see them on the slides. But when we identified how these different mechanisms were working, that then it became very clear that you need different types, or you need interventions that are very specifically geared to those types of informal payments. That just creating an accountability strategy would be unlikely to work on all of these. And in fact, in the case of number 3, surgical departments with these highly organized networks of different cadres who organized informal payments to reduce waiting times for some individuals, we didn't actually think that there was a strategy in which it would be possible to make those changes. So in conclusion, anti-corruption and social accountability and other forms of accountability, both aim to improve governance as a means to improve health systems, equity, access, and outcomes. In adverse settings, or for intractable, what we might call wicked problems, anti-corruption programs might be necessary alongside or prior to social accountability programs in order to make them more effective. Thank you very much.
Thank you so much, Dr. Leonor, for this insightful presentation. And as we can see, there are many variables playing to ensure that accountability really works. So as you mentioned, the inequity in power across the health systems, inequity in communities is a big issue that unfortunately is not addressed towards or with the usual tools and strategies in accountability in primary healthcare. So thank you so much to all speakers for having shared the experiences of South Africa and Ethiopia. And I will open the Q&A section. We have many questions. I will take the opportunity of this last presentation because there's a question, Dr. Leonor, regarding if what is needed in terms of the legal perspective to avoid anti-corruption, because we will need kind of teeth to tackle this problem. So what would you say about that? Thanks.
Thank you very much. Thank you very much. It's a really important question. I think thinking about the law and corruption and anti-corruption is absolutely critical. I think there are probably two things to say. I think, it's really important to have the policies in place and the laws in place in order to have a very clear framework on what is and is not corruption. And I think in some places we find it very difficult to get access to or to understand or to find health workers who are very clear about those policies, that those policies haven't necessarily, or those laws indeed haven't necessarily been laid out clearly. But notwithstanding, I think that that laws and policies really only get us sort of halfway to where we need to be, if they even get us that far. And I think anti-corruption policies in the past have really focused, in the first wave of approaches to try and tackle or curb corruption, we've really focused on legal systems. And I think we need to go way beyond the law into the health system to ask two questions. What is it that's driving this corruption? Are there gaps in service? Is it that health workers are so poorly paid that they either have to leave the health system to go and do another job and therefore are absent, or they stay in the health system and take informal payments? And so before you have your accountability strategy that pushes them to stay at the health centre, you need to do something about pay, or you need to do something about, opportunities. Are they leaving to get opportunities elsewhere? So yes, the law is important, but I think there are an awful lot of other things that have to happen alongside.
Yeah, sure. Well, I was recalling a study performed by the University of Otago from New Zealand in Nepal regarding the citizens' charters that were supposed to be posted in all primary healthcare facilities, displaying all the roles and responsibilities of the health facilities. And one of the findings they had in this study was that the health facility staff covered and hide the charters because, as you said, informal rules were the predominant and the community didn't have enough power. So apart from legal structures and strong anti-corruption policies, how would you recommend these problems should be tackled? How communities should be really empowered to keep staff, healthcare providers and authorities accountable and to diminish corruption in this way?
I think it's a really interesting case, and I've heard similar cases that, in places, I think one of the important findings that has come out of all of this anti-corruption work is that, informality is structured. It's not ad hoc. I think before we thought, oh, this is an ungoverned space. There are no rules here. There's no governance. Individuals are just doing what they want. You know, they're taking things for themselves. And I think now we understand much better that this is structured and it's about power. And I think when you're thinking about health facility committees, you also need to think about how they're made up and how powerful the people on those committees are. You know, it's not that you only want the most powerful in a community, but if you have very powerful local actors who are also involved in holding the facility to account, you know, according to, you know, the literature, I think they're much more likely to be effective. But so if you think about, instead of thinking about these informal rules and informal systems as something that you're constantly having to fight against, get to know them and see what's the potential in that system. Are there people in that system who can actually call people to account? You know, are there people who would be listened to because they're part of these informal structures and are actually quite powerful in them, and it's in their interest to do so? You won't always find a solution in that. You know, I think that's the other thing. You can't always find a solution, but start there. Look for your informal structures and look to, I suppose, double up what's in the informal structure and what investments, targeted investments, can we make in the health system so that together they can tackle this problem.
Sure, as you said, each case is different, so there must be in place like a deep understanding on how the problem roots are, and see how all together with the leading role of the health authorities, these problems can be addressed. So thank you so much, Professor Leonor. So I have a question for Dr. Janet. Could you please give us some insights on the practical steps toward accountability after the data are collected? Because, of course, we are all on the same page regarding the need of having indicators, a framework to perform the monitoring and evaluation. But then when all actors come together, analyze the results, and identify the problems, how the action plans to address these problems really contribute to this accountability work. So please give us some insight on how accountability after the data are collected works.
Thank you. We implement the framework through the plan, do, study, act cycle. And even in the beginning, when we started in 2014, it went through iterations because we kept on learning, and we learned from practitioners on the ground, the nurses, the doctors, physiotherapists, the community health workers, cleaners, groundsmen, and the communities themselves. What are the key elements that should in the first place be part of the standards? We have a nationwide email group where we get expert opinion. For example, when we decided what kind of what sizes of laryngoscopes has got to be on the emergency trolley, it is pediatricians and other specialists advised us on that. But to get to this particular question, and let me also say there's self-evaluations, but then there's also peer reviews, because you find that people are often not objective in evaluating their own situation and their own status. So the failures, you determine the causes of the failures, and in South Africa, it is 8 out of 10 times due to poor infrastructure. There's not enough space. Again, if you look at coverage in the community from community health workers, it could be due to resource constraints, that the particular district did not have the funding to appoint the correct, not appoint, to engage the correct number of community health workers, because the community health workers get paid stipends, and yeah, that's another issue. A lot of the failures is also due to poor supply chain processes in South Africa. Failures like the absence of required medication in the facilities, the necessary equipment, and so on. So we meet as a multidisciplinary team, and because this is a presidential and a ministerial priority, this year we actually resorted to meet with the 9 provinces and the 52 districts every 2 weeks. But we meet as a multidisciplinary team. You have the colleagues in charge of finance present. You have the infrastructure team, you have the human resource teams, and you have the supply chain teams. And then we plan collectively, because it is a developmental process. It's not a process that subjects managers and staff to punishment, but it is a developmental process. So we jointly determine what are the causes of the failures, and we meet as a multi-sectoral team to assist. Let me give you an example. When we started back in 2013, the district health services, meaning the primary healthcare services, would get only about 25% of the total budget that the provinces have. We've grown this budget to over 30%, working with our colleagues in finance, at the provincial level, at the national level, but then they assist us to influence colleagues at the provincial level. Thank you, Professor Bernal.
Thank you for your answer, Janet. Well, you mentioned that the discussions and the outcome of this accountability process doesn't necessarily lead to punishment. It has been reported that there might be like consequences of not being responsible enough, not being active enough to solve or to meet the population needs by the actors who had that responsibility. So how in the South African experience the commitment could be translated into real consequences to healthcare providers and health authorities? Is there any situation in which this happens?
Yes, an example would be a repeated absence of medication from a health facility. And key amongst those would be medications relating to our burden of disease priorities in South Africa, like TB, conditions of mothers and children, HIV, and so on. And if there's a complaint from the community, and there will be an informal investigation, and if that informal investigation points that there's no good reason for the prolonged and repeated absence of medication from a facility, the person in charge of the facility has to be taken through a formal disciplinary process. And that formal disciplinary process is applied in terms of South Africa's labor relations law. And depending on the transgression, how many times transgression has taken place, it does result in people getting dismissed. And because even discipline is progressive, first-time offenders may be put off work without salary for a period. Let me say, range from formal warnings to staying at home without a salary to actual dismissal.
Well, I ask that because often communities complain that even though they say they raise their voice, nothing happens. But I think we are all in agreement that the most important aspect of this accountability processes is that all actors are aligned and looking at the same perspective and on the same page, working together to have improvement in quality and not necessarily to push those that don't comply. But of course, this should be also in place. So thank you, Dr. Janet. I have a question for Dr. Mesele. How respectful maternity care and health bazar strategies ensure accountability?
Thank you, Professor. As you know, the components of accountability is to have some 6 standards according to our social accountability platform. The first one is we need to have a transparent service provision. So in respectful maternity care, we want to build the capacity of the healthcare providers and the service beneficiaries. So here we need to build a platform for both. And the other is, here is also a component of respectful maternity care and social accountability. It's accountability itself. We need to provide them high quality services. So we need to address high quality to the standard service for pregnant mother, those who visit the facility for delivery. And we also want to engage citizens. So there are a number of platforms to engage pregnant mothers in their care. So it's very important to bring here the respectful maternity care as a standard, as a quality of care, and accountability platform. The other important area is we also want to build the capacity of the healthcare provider as a professional. So this is a professionalism to provide a high quality, respectful care. So once we build the capacity of our healthcare provider, they will be responsive for a mother who is in pain during labor. So this is very important. The other one is we need also to have a transparent decision-making process. So this is a part of respectful maternity care. In their final decision, we want to engage them in their delivery outcomes and decision-making. And the other important thing is there is also a standard co-leadership in our case. So the healthcare providers, managers, leaders are the one who change the situation. So respectful maternity care should be considered as one of a social accountability platform to improve quality of service and to track and implement and be responsive for them. So this is one of a tool which can improve quality of service, which can be improved in our country. Over to you, Professor.
Thanks, Mesele. Well, indeed, knowing the right from the perspective of the patient, and also knowing the actions that healthcare providers have to perform, services they have to deliver, put everyone on the same page. So part of the accountability, a very important element of the accountability is that everyone is well informed. They know the rights, they know the procedures. One of the speakers commented, I think it was you, the importance of having guidelines. So health professionals know well what is expected to deliver. In the case of the pregnancy programs, they exactly know what the key variables are, and health authorities are able to offer support supervision, and also they have enough information to follow indicators and outcomes. So it's very important to have everyone informed. This is a relevant part of the accountability. So there's another question for you, Mesele. To what extent are the findings from community scorecards are used during the community facility forum to inform the discussion and change the problem into action plan?
Thank you, Professor. This is one of our area of improvement. In our country, as I already shared with you, there are about 600 districts, which is about 56% of our districts are exercising community scorecard as social accountability platform. And only 30% of our districts are organizing community and facility platforms. So we know this is very important because this is the area where we provide feedback for committee members, and this is one of the important elements which needs to improve. Our committee scorecard implementation have 6 elements, and facility and committee facility interface meeting is a very essential point which can improve the quality of service and ensure the responsiveness of the healthcare system for the public. And this is also a platform to improve the health literacy level, because the stakeholders are committee leaders, elders. So this is very important, and the healthcare providers and local administrators are there. So this is a very important platform, but only one out of 3 districts are exercising it, and it's our area of improvement in the future. Over to you.
Thanks, Mesele. I am also thinking or wondering how would you manage the illiteracy in the community? Because, well, one would think that to provide input on indicators and to provide monitoring on what is expected to be delivered by the healthcare facility requires a minimum of literacy from the community involved. So how you manage to have committee involved and meaningfully a meaningful participation on the committee in this committee scorecard work or function?
Okay, thank you, Professor. As I already pointed out, we do have a health post open house events, and this is a 3 days health bazaar. Committee members, the health facilities prepare themselves, and they just give a chance to be visited by everyone in their neighbors. So the committee members will get a chance to learn about their rights, the availability of services, and their needs and demands can be reflected. And as a part of the open house event, there is a committee and healthcare provider discussion points. So at that moment, they will raise a number of things. Maybe they demand different services which is beyond that the capacity of the local health posts. This is opportunity where the healthcare providers and committees are providing information on the capacity of the healthcare service levels and then the referral linkage, whatever. So we build the capacity of our committee members, including committee leaders and client councils through open house events. So that is the moment which give them power to learn the availability of services, the quality of services, and the standard of services. So having this element help the healthcare providers to provide more information within 3 days. And the other important thing is we do have also a family health guideline, which helps the healthcare extension workers to advise community members those services are available in nearby health posts as a referral point. And this is an important element to share community members. As client councils, we provide them like 6 hours orientations, and we capacitate them what the standard is, and they also verify the comments and suggestions of community members through visiting healthcare facilities. So we build the capacity of the committee representatives on the minimum standards and cares. And as governing board members, as the healthcare managers, they critically sit together and review what the committee says, what the standards, and they try to negotiate and bring the difficult things to close. So this is a moment how we build the capacity of our client councils, and they are the agent to give feedback for community members too. So the client councils also serve as an agent for community members on availability of service, minimum standards, the rights of the communities, and other demands. That's the way we implement. Thank you. Over to you.
Thank you, Marcel. So yeah, client councils is a very interesting strategy. So there's a need of building agency in the community to exert a better role on accountability. Community health workers is other good strategy, counting with people from the community that works as an ally between the community and the primary healthcare services. So yeah, very important. I will come back to Professor Eleanor with a question. What do you say about professional moral act would be while working on anti-corruption facilities?
Sorry, can you repeat that? Professional?
Yeah, what do you say about professional moral act would be while working on anti-corruption facilities?
So the sort of morality about the professionals, is that what that question's about?
Yeah.
So I think that's a really, really important question. I think it's actually at the heart of some of the reasons why people find corruption and anti-corruption difficult to think with as health systems, analysts, practitioners, because I think for years and years we've thought about corruption as immoral and people involved in rule breaking as completely immoral. And what we're trying to do when we do all of this work on anti-corruption is think about, okay, you're always going to have people, a few people who are engaged in these activities because they are just seeking to benefit themselves and they're not thinking about other people. But I think that what we're trying to do is differentiate those people who I think very much, you know, should be countered by rule of law, to the people who are driven into rule breaking because of demands made on them through particular sort of socio-political networks, maybe through the problems and difficulties that there are in the health system, and to sort of make sense of that. So I think thinking about values and morals is, you know, it's never a sort of, well, it can be actually, but I think if it's done in the right way, and if it's done perhaps at medical school, talking to people about corruption, about sort of the values they have, the morality of their professional practice, I think that's important. But I don't think it can, it's a small part of, I think, what it is that you need to do. And I think once you start sort of unpicking the really complex circumstances in which people find themselves living, then people often know, well, yeah, if I had a choice, I wouldn't do that. But actually I have to do that because otherwise, you know, I can't survive, my family can't survive, I need to get home. Sort of variety of factors.
Thank you, Professor Leonard. We have just a few minutes before we end this session. I will come back to Professor Janet with a question on what are the challenges in integration of finance to accountability.
Thank you, Prof. Bonal, for that question. I'm wondering if the question is about if we have a framework in South Africa, how is it?
I guess, yeah, I guess it is about, you presented several domains within the framework. So what is the role of finance in the accountability framework in South Africa?
Yeah. So even when we started the framework in 2013, we had opposition from the Treasury, who always guards against additional expenditure. And we became like stuck records to explain to them we're not asking for something extra, that there is a budget in South Africa for the district health services, meaning the primary healthcare services, including district hospitals. And that this is a way of defining clearly what is expected, because there was an external review done and 0 facilities met compliance standards, which means you have to start from the point that people do not know what they have to do. You cannot go to discipline and punishment when you've not given the tools that explains what they need to do and you've not taken them through training. And while we said that this is not a new mandate, so it doesn't need additional money, we did motivate that over time the budget for primary healthcare services should increase. So my answer is it's already there. We've had the district health system since we started government in 1994. It has always had a budget, and these things that are defined within the accountability framework are things that should have been done since the beginning of a health system. And so now you've defined it, you've put it into a manual, you have trained people, they no longer have an excuse, and you just need to make sure that you grow the budget to assist them with resources. You progressively grow that budget. Thanks, Professor.
Thanks, Janet. Well, would you say that in the framework there is like specific aspects regarding how health managers spend money, how they distribute the resources they receive, and how this is a very important part of the accountability processes in health facilities?
It is not explicit in the framework that the facility should be managing the resources able to answer to all the requirements of the framework. So that one is not there, but they do have the resources, and what the framework describes is what they need to do with those resources. And And maybe this is something we should apply our minds to, that should you include within the framework training for managers on financial planning and managing budgets. So definitely food for thought. Thank you.
Excellent. Perhaps last question for all is, you talked about limitations on the from the health system itself and health facility itself regarding infrastructure, regarding information systems, even data, right? Perhaps we don't collect quality data to facilitate accountability. How to approach or how to tackle these infrastructures limitations to improve accountability in primary healthcare?
You're saying it's a question for all? So
yes.
Is it for all the speakers?
You can start. Yeah.
I will start. What we were thinking, that with infrastructure, our experience in South Africa is not that we do not have the infrastructure, but over time, due to a lack of proactive maintenance, the infrastructure becomes run down, and that is costly because now you have to invest more than what you would have needed to invest if you maintained your infrastructure well. And in line with our approach to define structures and set them up and clearly communicate what they need to achieve, we set up these, or recommended to provinces to set up the infrastructure hubs, that districts should actually have outreach teams that does proactive maintenance. I want to speak a little bit about data because it's a problem in South Africa, in that we have many disparate systems collecting data about multiple facets of the health system. And what we lack is an overarching information system. And I know one system cannot answer all the questions. It's not advisable to have everything on one system, but you at least would need a data pool that would pull in then data from different sources, so that you could have integrated information. And I think the tools are there in 2023. The information and communication tools are there, but for us as a country, it's about, again, the resources to implement this. We were looking at having mobile apps for the community health workers, to not use paper forms, but to directly enter household data during their household visits onto forms on mobiles, so that the information is electronically transmitted, to start to build, a pool of information about the communities we serve. But just 2 weeks ago, the quotation we received from such an application is just prohibitive, and with a health system with competing demands, spend on health technology is always going to be further down the queue. If you look at, you have to invest in doing cervical cancer screenings. You have to invest in doing TB defaulter follow-up and so on. Let me stop my input there. Thanks, Professor Bernal.
Thank you so much, Janet. Professor Dr. Mesele, would you say any words towards this question?
Okay, thank you. As previously stated, especially infrastructure, data quality, and information system is difficult in our setup. But the social accountability platform do have also some merits, especially while we are engaging the local government, and we just give them opportunity to listen the opinion of communities. They are trying to improve the infrastructure through allocating additional budgets, like improving clean and safe facilities demand a lot of money. But you see, in our country, the number of districts which share 50% of the total budget is too few. But when we show the feedback and engage the local leaders, mostly they are not a healthcare providers or health professionals. So they are social science professionals or some other fields. So when they closely work with the committee members, the client councils, and the healthcare providers, it gives us a chance to mobilize additional resources to improve the situation. Though we are far from the standards, it gives the social accountability platform gives us a chance. Like Janet says, in our country, we do have also a simple exercise with electronic health information system for the community health worker, but it is too far for us. We do have more than 70,000 community health posts, but in less than 1,000 health posts, we are exercising the digital platform. But since we use a paper-based things, what we should work as on our healthcare providers and community health workers. We need to show them the importance of high quality data for decision making and its impact on the health of community members. So it takes us some years to improve things and make good data and a good infrastructure, but there is an initiative here and there. So I believe it can be improved in the coming few years. Over to you, Prof.
Thanks, Marceli. Professor Leonard, to close.
Very quickly, I suppose. I think investments need to be made that address inefficiencies in the system, and that they can then hopefully have a knock-on impact or effect in terms of the sort of informalities and corruption and poor accountability that are in place. But I suppose I would like also to sort of end on a sort of note of warning. I've worked on data, and pushing health workers into collecting more and more data more effectively can have a terrible impact on the care that can then be provided, because they don't actually have time to care for their patients. So always, I suppose, working out the impact of what it is, of the changes that you're seeking to make. Thank you very much.
Sure. Well, definitely not a simple question and not a simple solution. Accountability in primary healthcare involves a high complexity. Many variables together should work well. Perhaps the infrastructure aspect could be one of the most difficult aspects to address to ensure a good accountability. But well, I think even though that we spent a few minutes more on the expected time, it's been a very rich discussion. Many perspectives were brought from our speakers, and the audience was very participative. I'm very sorry that we couldn't cover all the answers and comments we saw in the Q&A function, the chat function, but for sure there will be food for thought on this relevant topic in primary healthcare. So I thank you very much to all speakers, to the audience, and I give the word back to Antoinette.
Okay, thank you so much, Professor Luis, for excellent moderation, and as well the speakers for a very important perspective that you shared for the audiences. I hope participants and audiences get a lot of insight from these presentations and discussions, and we'd also would like to thank the participants for your active engagement and attending our sessions. So thank you. Have a good rest of your day. And also I would like to request the participants and audiences to follow our consecutive webinars that we'll be having. The next webinar will be on October 4 and on supply chain in primary healthcare. And there are a lot also coming in the future. And please visit our website so that you could get other important information and resources as well. So thank you again for all the panelists and for all the participants. Have a good evening and day for all.
Thank you. Thank you.